Welcome, everyone. My name is Ted O'Connell. I'm one of the authors of Crush Step 1, the ultimate USMLE Step 1 review. This is the second edition of the book, and we're going through it chapter by chapter. This is part 7 of the Cardiology chapter. We're going to start by talking about hypertension. Known to the public simply as high blood pressure, hypertension is a major risk factor for numerous causes of morbidity and mortality, including coronary artery disease, strokes, heart failure, and renal failure. Because hypertension is often asymptomatic, it is termed the silent killer. About 90 to 95% of hypertension is essential or primary hypertension, and the remaining 5 to 10% is secondary hypertension. Essential hypertension comes from a mix of genetic factors, obesity, lifestyle, and dietary factors. Secondary hypertension has discrete causes that are often curable if recognized, so the causes of secondary hypertension are important to keep in mind. And please note that most of these will be covered in detail in Chapter 9. Let's start, though, with renovascular hypertension. In Chapter 9, the renin-angiotensin-aldosterone, or RAA system, is explained in detail. Briefly, whenever the kidney JG cells see less blood, they will think the blood pressure is low and act to increase it. If the renal arteries are stenotic, which in older adults occurs because of atherosclerosis, and in younger women because of fibromuscular dysplasia, the JG cells will see less blood and secrete renin to activate the RAA system and increase the blood pressure. The increased angiotensin II causes vasoconstriction, and the increased aldosterone causes sodium retention. Diagnosis is by plasma renin activity. In the setting of high blood pressure, renin should be low, but it will be high in renovascular hypertension. Aldosterone levels will be high in both renovascular hypertension and primary aldosteronism, but renin levels will be low in the latter. Next is primary aldosteronism, or Conn syndrome. This is caused by an aldosterone-secreting mineralocorticoid tumor in the zona glomerulosa of the adrenal gland. Primary aldosteronism causes increased blood pressure by increased sodium retention by the kidney. Levels of aldosterone are high, but renin levels are low because the aldosterone is being secreted directly by the tumor. Next is pheochromocytoma, a catecholamine-secreting tumor most commonly found in the medulla of the adrenal gland. 10 to 15% are extra-adrenal, though. And this causes paroxysmal hypertension and sporadic episodes of palpitations, diaphoresis, and headache owing to intermittent release of epinephrine and norepinephrine. Next is Cushing syndrome. Increased glucocorticoid levels as a result of 1. An exogenous cause, such as prescription steroids, 2. An adrenocorticotropic hormone, or ACTH, secreting tumor in the pituitary gland, which is termed Cushing disease, 3. An ectopic ACTH secreting tumor, for example, small cell carcinoma of the lung, or 4. A corticosteroid secreting tumor of the zona fasciculata of the adrenal gland. ACTH stimulates corticosteroid secretion by the adrenal gland. The reason for increased blood pressure in Cushing syndrome is twofold. Glucocorticoids such as cortisol in high levels can attach to aldosterone receptors, thus functioning as mineralocorticoids, as well as cause increased sensitization to adrenergic agonists. Alpha-1 stimulation vasoconstricts the peripheral vasculature. Beta stimulation increases cardiac output. Patients often have typical stigmata of Cushing syndrome, such as moon facies, a round face, central obesity, hemorrhagic purple-red striae, and hirsutism. Regardless of etiology, hypertension causes increased afterload on the left ventricle, potentially causing heart failure over time. In addition, direct arterial damage from the high pressures leads to accelerated atherosclerosis, which can promote myocardial infarction, stroke, and organ failure such as renal failure. Now let's move on to ischemic heart disease. Ischemic heart disease occurs when there is an imbalance of myocardial oxygen supply and demand, leading to inadequate oxygenation of the myocardium. This can lead to angina, myocardial infarction, or chronic ischemic heart disease. Angina is a squeezing or pressure-like sensation in the chest that patients have during myocardial ischemia. There are 3 types of angina that must be understood. First is stable angina, which occurs during exertion, is relieved by rest, but is not worsening and is therefore stable. Typically secondary to stable, non-occlusive atherosclerotic plaques in the coronary arteries. To be symptomatic, the severity of stenosis typically is at least 70%. Next, unstable angina. This is angina that is worsening, such as with less exertion, or is occurring at rest. Unstable angina is often due to non-occlusive coronary arterial thrombi, which could potentially become completely occlusive. Therefore, this is a medical emergency because it may progress to a myocardial infarction. And finally, Prinzmetal or variant angina. This angina usually occurs at rest and is not due to atherosclerosis, but rather vascular spasm. Now let's talk about chronic ischemic heart disease. With chronic oxygen deprivation, there is progressive congestive heart failure, or CHF, that can be due to replacement of ischemic cardiac myocytes with non-contractile fibrous tissue over time. Now let's talk about myocardial infarction. Myocardial infarction, or MI, is typically from thrombus formation from a disrupted atherosclerotic plaque in a coronary artery, resulting in ischemia and death of myocardial tissue. Whereas in stable and unstable angina, no heart tissue dies from the ischemia, in MI there is coagulation necrosis. These MIs can either be an ST elevation myocardial infarction, or STEMI, or non-ST elevation myocardial infarction, NSTEMI. STEMI is ischemic and necrosis involving the entire thickness of myocardium due to occlusion of a coronary artery, leading to ST segment elevation on the ECG. It is transmural because the coronary artery branches are responsible for perfusing all 3 layers of the heart. Blockage causes cessation of blood flow to all these layers. NSTEMI is ischemia and necrosis. It is usually involving only the innermost part of the heart. The subendocardial area is the farthest from the coronary arteries and therefore is the last to be perfused, with the fewest collaterals supplying it. In addition, the contracting myocardium exerts high pressure in this area, reducing blood flow further. This is usually due to hypoperfusion from either generalized hypotension or a coronary artery that is not completely occluded, but rather is narrowed enough to cause death of the most starved myocardial tissue. There is usually ST segment depression on the ECG. The ECG is very helpful and can show ST segment changes as well as pathologic Q waves. These are Q waves that are greater than 1/3 of the height of the QRS complex and can be a permanent change after an MI. The ECG is what is used to initially diagnose a STEMI. In the correct clinical setting, the patient should be treated with cardiac catheterization immediately, or, if unavailable, with thrombolytics. When myocytes die, their cellular contents are released into the bloodstream and aid in the diagnosis of an MI. Troponin I rises within 4 hours and stays elevated for 1 week, whereas CKMB, creatine kinase, rises essentially as fast as troponin, in a range of 3 to 8 hours, but normalizes after about 3 days. CKMB is also less specific than troponin elevation because it may be released from cells other than just cardiac myocytes, such as skeletal myocytes. A positive troponin and or CKMB in the correct clinical setting establishes the diagnosis of an NSTEMI, as long as the ECG does not demonstrate a STEMI. There are many complications of MI, from the second it happens to weeks afterward. First, arrhythmia. Fatal arrhythmias are a common cause of death before hospitalization. In the hospital, arrhythmias are usually immediately recognized and treated because of cardiac monitoring and access to defibrillation. Damaged cell membranes and sections of dead myocardium all promote abnormal conduction and arrhythmias. Ventricular fibrillation is the most common fatal arrhythmia in acute MI. Next, myocardial dysfunction. With the death of myocardium and possible ongoing ischemia, the ability of the heart to function as a pump is compromised. With large MIs, cardiogenic shock can occur immediately, causing severely decreased cardiac output and hypotension. But delayed heart failure can also occur. Next, papillary muscle rupture. With some MIs involving the left ventricle, the papillary muscle can rupture, leading to acute mitral regurgitation because the chordae tendineae no longer function to prevent regurgitation. Ventricular free wall rupture. This usually occurs when macrophages begin to remove necrotic areas, causing a weakening, typically between days 3 and 7 after an MI. This leads to rapid bleeding into the pericardium, resulting in pericardial tamponade and death. Next, ventricular aneurysm. This is a late complication occurring between 1 and 2 months after the MI. Weakening of the ventricular wall leads to fibrosis and dilation without rupture, unlike ventricular free wall rupture, which is a relatively early complication with rupture. This is a late complication because fibrosis takes time, just like scar formation. The fibrotic aneurysmal area cannot contract, leading to congestive heart failure and potential clot formation in the ventricle from stasis of blood. Next, fibrinous pericarditis. Early after an MI, within the first week, the inflammation caused by the necrosis of myocardium can cause increased vessel permeability and exudate formation. This is directly caused by inflammation, unlike Dressler syndrome. Dressler syndrome, or autoimmune fibrinous pericarditis. When the myocardium dies, it releases cellular contents that the immune system has not seen before. The body can see these as foreign and develop an autoimmune response to them. This leads to autoimmune pericarditis that usually occurs 1 to 2 months after the MI. That's the end of this section. In the next, we're going to discuss congestive heart failure.